Hello, and thank you for joining us for this session, The Impact of the Pandemic on Quality of Life for Those with Ovarian Cancer. I'd like to thank our sponsor, AstraZeneca, for making this session possible. In this session, you will learn about the results of a large patient survey and hear from a gynecologic oncologist and survivor about their experiences with cancer through COVID-19. Our speakers for this panel include Annie Ellis, who is an ovarian cancer survivor and research advocate, Dr. Melissa Frey, who is an assistant professor of obstetrics and gynecology in the Division of Gynecologic Oncology at Weill Cornell Medicine in New York, and Cassandra Polite, who is an ovarian cancer survivor. You can view their full bios in the downloadable conference program. I want to thank our speakers for joining us today, and let's get started.
So let's go to our first slide.
So to outline what we're going to talk about today, we're going to start by our discussion of quantifying the patient voice. Then we're going to talk about some of our past projects and insights. We're going to review a patient story from Cassandra Polite. We're going to review our COVID-19 survey and findings, some conclusions, and ongoing considerations.
So first thing is, my role as a research advocate is to bring a broad perspective into the dialogue with researchers and the scientists. And researchers and doctors speak in the language of data. And by using a survey, we can take the patient voice and turn it into data. The more voices we can capture, the better. So my surveys will always be seen by medical professionals. One example of the patient voice being captured in a survey is the Ovarian Cancer Symptom Survey. Cindy Malassa was a nurse and ovarian cancer survivor. She was the editor of Conversations, which was a snail mail newsletter, and this is how survivors connected before the internet. She partnered with Dr. Barbara Goff, and together they put this survey in the newsletter. And what was extraordinary is that they received more surveys back than what they had mailed out. People had copied that and shared it in support groups. And the survey was published in the American Cancer Society's journal and led to a prospective trial, which was also published in JAMA. And this led to the consensus symptoms. Those of you who are survivors teaching students presenters may recognize these core symptoms. And quantifying the patient voice through a survey was the first step in this important process. So our voices matter.
A few years ago, Annie Ellis and I started collaborating, and we were really interested in improving survivor-physician communication because from a physician standpoint, I noticed that when I would see a patient, I would ask her, how is she feeling? And once I gave her information about a good CA-125 result, the symptoms sort of disappeared and there was this sort of very positive outlook. But then when I would speak to nurses, physician assistants, family members, we'd learned that actually our patients had many, many symptoms they weren't telling us. Because really, from a patient perspective, there's this sense that I don't want my physician to lose faith in me. I want them to treat me and see how strong I am. And we realized that that's not the best way to have an alliance between patient and physician. And so we had to think of better ways to improve that communication sort of with the shared goal of having the best treatment and the safest treatment. So we started a collaboration with Dr. Stephanie Blank from Mount Sinai Icahn School of Medicine. Our first project was a focus group where we really concentrated on ovarian cancer survivors' perceptions of endpoints and goals of care. The next step was to do an in-depth study of the way that ovarian cancer survivors accept and think about treatment and disease side effects as cancer over the course of the cancer continuum. And then finally, we looked into how can we bridge this gap? How can we improve communication and shared decision-making? We came up with a priorities assessment tool that could support shared decision-making and really maximize time in the office between patient and physician. And what did we learn from these exciting collaborations? Well, we learned that ovarian cancer survivors identify communication with their physician as an essential element in determining treatment course. Ovarian cancer survivors, not surprisingly, prefer an individualized approach to cancer care, balancing both survival and quality of life. And then finally, that ovarian cancer survivors value tools that can enhance communication and promote shared decision-making. So the example of the tool that we studied in our pilot study and now an ongoing prospective study was this patient-centered priorities assessment tool, which is a validated ovarian cancer symptom index combined with an index to assess daily quality of life priorities. So just to switch gears and bring in the topic of COVID-19, I'll take you on a timeline of early COVID-19. On January 9th, the WHO announced a mysterious coronavirus-related pneumonia in China. On January 21st, the first case was identified in the United States in Washington State. On February 3rd, the United States declared a public health emergency. The first case in New York was identified on March 1st. And then on March 22nd, New York City prohibited elective procedures. And this was critical because elective procedures included many of the things that go into the diagnosis and treatment of cancer. So we know that about 5,000 people in the United States are diagnosed with cancer each day, and many more are undergoing treatment for a known cancer diagnosis. And so, especially in these early days of the COVID-19 pandemic, many of these patients were not able to get the treatment and the care and the diagnostic studies that they needed.
Now we're going to hear from Cassandra. She's going to share her story about how the pandemic interfered with her treatment.
Hello, everyone. My name is Cassandra, and I'm an ovarian cancer survivor. I was initially diagnosed in November 2016. I had the debulking surgery the next month in December of the same year. And over the next 7 months, I completed 6 rounds of carbotaxol. During this time, I found out that I was BRCA1 positive. So upon finishing treatment with no evidence of disease, I returned back to work in August 2017. Fast forward to September 2019, I had a recurrence. I did 3 more rounds of chemo, then had surgery in December 2019 with the placement of a colostomy. After surgery, I had 3 more rounds of chemo, this time that consisted of Taxol and Avastin. So the COVID-19 has had an enormous impact on the way treatments are done now. So I noticed, well, I had to wear the mask, of course, upon receiving treatment, and we were all socially distanced with the markers on the ground, so we wouldn't be too close. And I found the mask to really be annoying because I couldn't breathe half the time properly in it, and it really dried my throat out a lot. So that was, well, I guess that's everybody's going through that inconvenience of wearing the mask. And another way the pandemic has affected my treatment is by prolonging my colostomy reversal surgery. Prior to the pandemic, my reversal was scheduled to be done a month after completing chemo. Once the pandemic hit, of course, all elective surgeries were postponed. Now that elective surgeries are open again, I'm still waiting to get clearance, as there is some confusion as to whether I can get the reversal or not. So I'm frustrated because things haven't gone the way that I planned it to or initially. So now I'm looking for a gynecological oncologist to confer with my colorectal surgeon to see what happens next. Also, being the parent of a minor child during this time has been challenging. Dealing with remote learning while managing the side effects from treatment was no easy task. So I'm grateful that my son's school would give assignments on a weekly basis. Then they would do each evening. That gave us all day to complete it. And luckily, his older siblings would help out often when I was too fatigued to finish the work. So I've personally been coping with this pandemic and treatment by getting outside for daily walks as much as possible in my neighborhood. The sunshine and the fresh air is always uplifting and invigorating for me. So I try to go out as early as possible to avoid crowds. I also stay in contact with family and friends through weekly phone calls and texts. I'm so grateful for organizations like SHARE and the support groups that they provide. The Zoom meetings have been an invaluable help to me in staying connected to others while remaining social distance. Andrea, one of the support group facilitators, has been particularly encouraging and inspirational with her story. As of now, I'm currently on a part 1 inhibitor for maintenance, and so far, fingers crossed, lab work, blood work, everything is doing good, looking good. So moving forward, I'm looking forward to having my colostomy reversed. I will continue to advocate for myself in having it done as quickly as possible with safety in mind, of course. I also look forward to traveling to the convention in person next year with you guys. Hopefully the pandemic will be over.
Thank you, Cassandra. Thank you so much for sharing your story with us about how the pandemic has impacted your treatment in all aspects of life. Your story inspires me, and it inspires us to do our work.
The pandemic brought rapid changes. From the perspective of a physician, our number one priority always was to care for our patients, but we had to do so with little reliable data and rapidly changing regulations. And also we had to be mindful of our institution's responses to regulations and to this ongoing dynamic situation.
From the patient perspective, we had a lot of concerns as well. We didn't know what our risk was. Were we at more risk because of our cancer history, even if we weren't in treatment? And how do we stay safe? How do we reduce that risk? We also weren't sure what to be more afraid of, cancer or COVID-19. And because things were changing so much at institutions and there were lags in communication. So there were people who arrived for treatment not knowing that their family member couldn't come inside with them, and that led to a lot of stress. Also, we were concerned about limited resources. How were we going to get groceries and the cleaning supplies that we needed? And also, if there were to be an outbreak and we got sick with COVID-19, would we get a ventilator?
So with all of this in mind, we designed the COVID-19 survey, which opened on March 30th.
So I want to say very quickly what a privilege it has been to work with Dr. Frey and Dr. Blank in the past and on this survey. They are so concerned with what their patients are going through and how to improve communication at all times. And they were really concerned with how their patients were coping during this difficult time with all the changes and treatment disruptions. So it was very important to have validated tools to measure worry and anxiety and depression. And that made the survey very long. So we appreciate everybody who stuck it out towards the end. But what this did reveal to us is that some of the, a COVID-19 stress tool did not exist So we used the best available, which were the Cancer Worry Scale and the Hospital Anxiety and Depression Scale. And it revealed that these current tools might not capture what managing chronic disease with targeted therapies. People are living with cancer, and it might not accurately measure that, but it is the best we have, and it did give us some really good information. We also captured whether somebody had COVID-19 symptoms and what information about their diagnosis, treatment interruptions, their cancer and health history, some demographics, and we also wanted to know about their top 3 concerns and what strategies they were using to cope. It was open only for 2 weeks, so this information was as of April 13th. And what was extraordinary is that we received IRB approval for this work from 2 institutions in just 4 days. I also want to, at this time, give a quick shout out to our distribution partners. We shared this on SurveyMonkey through social media, and many people, including OCRA, helped get this information out there.
So to date, the study has resulted in 1 publication in the American Journal of Obstetrics and Gynecology, and we have another publication in submission. And so we're very, very excited about these results, and the scientific community seems to be equally excited about reading about our results. So I'll just take you on a brief tour through some of our findings. 555 ovarian cancer survivors completed the survey. These women came from 6 countries and 41 states in the United States. We collected information on age, race, ethnicity, relationship status, and living status. We also collected oncologic information. So about 30% of our patients had early stage ovarian cancer, and about 60% late stage or stage 3 or 4. The majority of women had completed their first-line treatment, and 43% of women were currently receiving cancer-directed therapy at the time they completed this survey. We were interested in medical comorbidities because much of the news and medical literature that was coming out at the time demonstrated that individuals with other medical illnesses had increased risk of COVID-19 related severe disease, and that was in addition to the cancer diagnosis. And so we found that some of our participants had diabetes, chronic lung disease, chronic kidney disease, and coronary artery disease. We collected cancer history from our participants. About 30% of participants had early stage ovarian cancer, and about 60% late stage or stage 3 or 4 ovarian cancer. The majority of women participating in this study had completed first-line treatment, but about 43% were actively receiving cancer-directed therapy at the time of survey completion. We were interested in looking at medical comorbidities experienced by our population because the literature coming out at the time showed that cancer, but also many other medical comorbidities, could increase the risk of possibly contracting COVID or having a severe outcome if COVID-19 infection happened. And we did find that our participants had diabetes, chronic lung disease, chronic kidney disease, and coronary artery disease. We also asked about COVID-19 symptoms and found that about 11% of our survivors reported some COVID-19 symptom. And most common symptoms reported were fever, cough, and shortness of breath. As you can tell, this was very early in the pandemic. And so this is before, this was when testing was less readily available. And so only about 2% of our population, or 12 participants, underwent COVID-19 testing. And among this group, 3 tested positive. So what did we find regarding treatment disruptions? And this is something that as physicians, we are very concerned about because we knew that it was inevitable that patients would undergo disruptions to their cancer care. So 175 participants, or about a third of the group, reported some delay in their cancer care. Among women scheduled for systemic treatment, 8% had a delay in treatment, and among women scheduled for a cancer-directed surgical management, 26% had a delay in this surgery. Among the whole population, 24% of survivors had a delay in an oncology appointment, 15% a delay in a cancer-related laboratory test, and 10% a delay in cancer-related imaging. Finally, we studied cancer worry, anxiety, and depression, and we found extremely high levels of cancer worry. About 89% of our population reported high levels of cancer worry, which is greater than any number we have seen in prior literature on women with ovarian cancer. 51% of our survivors reported anxiety, with 28% reporting high anxiety and 23% reporting extremely high anxiety. And 27% of our survivors reported depression, with 19% reporting high levels of depression and 8% reporting extremely high levels of depression. We performed a multivariable analysis of these outcomes. And the reason we did this is, as physicians, we wanted to know which of our patients were at highest risk for cancer worry, anxiety, or depression, or how could we predict who would be most likely to have these outcomes. And so we found that cancer worry was associated with younger age, being scheduled for cancer treatment, and being self-described as immunocompromised. Anxiety was associated with age less than 65, a delay in oncology care, and being self-described as immunocompromised. And then finally, depression was associated with age less than 65, living alone, a delay in oncology care, lacking access to counseling, and being self-described as immunocompromised.
So with every survey that I do, the part that touches me the most are the answers from participants in their own words, and this was no exception. We asked what people's top concerns were right now, and this word cloud captures, a lot of what that was going on, as well as the sample answers. And it's very clear that women with ovarian cancer have a lot of concerns, and there's a lot on their plate, from dealing with their cancer to taking care of their families and the finances, as well as thinking about the world and the future. And, it takes a lot of work to quantify this and to measure it.
We collected all of the participants' responses to this question and then kind of placed them in order. And we found that the most common concern, not surprisingly, was COVID-19 infection, followed by cancer recurrence, safety of family members, and access to cancer care. We were surprised by the fifth most common answer, which was the financial implications. And I think this is absolutely critical, because I think that the medical community doesn't really spend as much time considering financial implications and financial toxicity of cancer and treatment. And I think this is really absolutely critical, and we're so happy that this was emphasized in our study findings.
And moving on, the next open answer item was we wanted to know how people were managing their stress. What were they doing to get through their days? And again, here is a word cloud capturing the totality of what the answers were. And again, it takes a lot of work to turn that into data.
I just want to thank Annie for adding this question to our survey, because this is probably one of the most useful things that we learned from our survey, which was, how are women coping with COVID-19 and cancer during this pandemic? And some of the things that we found as the top coping mechanisms were self-care, hobbies, self-distraction, planning, positive reframing, and religion. There's a very large literature on coping strategies, and often researchers will try to categorize coping strategies into those that are adaptive or helpful in the long term versus those that are called maladaptive or dysfunctional, which can be helpful in the short term, but not as helpful in the long term. So we tried to use prior literature to categorize all of the coping strategies reported by our survey participants. We were happy to find that 91% of participants reported using at least one strategy that could be deemed as helpful or adaptive. And just to give you a selection of some quotes of participant answers to these questions that demonstrated a positive or helpful coping strategy: prayer, choosing to be joyful, hopeful, grateful; humor, maintaining favorite outdoor activities, qigong; keeping a routine, I am lucky and still able to work and love my coworkers; walks with the dog in this gorgeous weather; small projects that have realistic goals and ends, a sense of accomplishment; being vocally grateful for home, family, food, rural countryside, community; having a daily routine that provides a bit of structure and purposeful activity, but is not too rigid; daily exercise, preferably outside; lots of phone, online communication with friends and family; eating well; something fun each day; some quiet time each day. We also found that about 36% of participants reported using at least one of the strategies that we would call less helpful or maladaptive. And so some select examples would be bouts of extreme sadness and crying, napping to escape reality; I have a cocktail every night with my husband, and I also have a prescription for 10 milligrams of lorazepam if things really get me anxious; eating unhealthy snacks.
And I just want to jump in here and let everybody know there is no judgment. I've done all these things, most of them more than once. And, a girl's just got to do what a girl's got to do to get through in the moment. But I think we do need to be aware that if these continue long term, or it's the only way that we're coping, it could be a sign of depression. And there is help that somebody can get for that. And we hope that you reach out.
Technology was an interesting subject in our findings because we found that it can have both a positive and a negative impact. 13 women, or 3% of our population, reported needing to limit access to social media and the news in order to cope. And actually, if you look at the CDC website, they encourage limiting exposure to news about the crisis as an active and adapting coping strategy. But also we found that 20% of our population were able to access emotional support, so speaking with friends and family members and getting that needed support through technology like Zoom and FaceTime. So in a time with quarantine and restrictive social distancing, technology actually gave our participants a way to connect, which was a very positive coping mechanism.
So our conclusions, and again, just remembering that this survey closed on April 13th, so all these numbers are, may have shifted. But at the time, 1/3 of the women with current or prior ovarian cancer experienced a delay in their cancer care. We know that number is much higher now. Close to 90% reported significant cancer worry. And younger age, presumed immunocompromise, and delay in care were associated with a significant increase in cancer, worry, anxiety, and depression. And so we want oncologists to stay well informed on the emerging data that addresses COVID-19 and cancer, and incorporate this into their patient care so that they keep people safe from COVID-19, as well as treating cancer in a safe way. And we want oncologists to screen their patients for their psychological, psychosocial well-being, and have a way for patients to get support, recognizing that communication is a very important tool in these times.
So what are the ongoing considerations? Unfortunately, COVID-19 is an ongoing healthcare crisis, so we have to continue to reduce the risk of COVID-19 with social distancing, masks, hand washing. Women with cancer, though, must continue to have treatment and follow up any needs that they have. So we have to be able to deal with COVID and cancer at the same time. And so it's very, very important that for women with cancer who have symptoms or concerns to contact their physician. Technology is, again, positive and negative. Avoiding some technology, like the news, is positive, but using technology to connect with others to overcome isolation can be wonderful. And telemedicine is also a way to maintain the doctor-patient relationship and communication when in-person visits are not possible. So this can be telemedicine for oncology appointments, but also non-oncology medical appointments and mental health appointments. And so we really cannot highlight enough the importance of communication. Do not hesitate to contact your care team if you have questions or concerns. Don't hesitate to contact your care team for additional help with telemedicine issues. And just remember, there are going to be many barriers to communication. One big one is masks. It's very difficult for people with hearing issues and people in general to have the same types of communication when we're wearing masks and face shields. But don't hesitate to ask for clarifications, because really the goal here is to maximize communication.
And we do want to leave you with a few resources. If you are not connected to local or national or online resources, you can always reach out to your hospital social worker to see what support resources are available nearby. OCRA has an oncology social worker who's available. Ask for Tracy. And a woman-to-woman program, I believe they've been meeting through Zoom once a week. Share Cancer Support has an ovarian helpline staffed by ovarian cancer survivors who provide peer support, and you can reach them by phone or by email. And the Foundation for Women's Cancer, which is the Society of Gynecologic Oncology's foundation, has resources on the coronavirus, as well as a Steps Through COVID-19 webinar hosted by Clarity Foundation, and Dr. Shannon Armbuster did a webinar on the benefits of movement and gave some ideas of things that you can do at home.
We want to close by thanking you. We are so grateful for the survey participants. It was a very long survey, and we were just really surprised and excited and checked every morning to see how many surveys were coming in, and we just couldn't be more grateful. We're so grateful to the distribution partners for allowing us to get this survey out. Especially thankful to the OCRA for the ability to talk today and share our findings and the interest in this topic and our findings. And then, of course, I want to thank Annie and the whole team of researchers who contributed to this work.